Patients here.
Oh boy, got some blood going.
Yeah, there's never blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver of a vehicle, appears that she went off-road into a ditch, rolled over her car into a tree, caved in, the top of the vehicle was caved in, and she was hanging out partially from the window. She's been in application
for 45 minutes of CPR. We can stop CPR with 600, 600, 600.
Welcome back to the Deep Dive. It's great to have you with us. Today we were doing something a little different, and frankly, I am really excited about it. Usually we take a stack of articles, maybe a big nonfiction book or some tech reports, and we pull out the insights. But today we're going to medical school. Well, nursing school, specifically.
That's right. We're pivoting to look at a very specific, high-stakes area of pediatric healthcare. And honestly, this is some of the most complex material you can encounter in a clinical setting.
We're tackling the pediatric immune system. And before you tune out thinking this is just going to be a dry biology lecture, let me stop you. We're looking at a source specifically designed as a clinical survival guide. We're calling this the exam hack session. We have a massive stack of notes here covering chapter 25, which deals with alterations in immunity.
It really is a survival guide. The material we have is dense. It covers everything from kids with, literally zero immune system to kids whose immune systems are overactive and attacking their own bodies. It's a whole spectrum of invisible warfare happening inside these children.
So our mission today is simple. We're applying the Pareto principle, the 80-20 rule. We want to extract the 20% of the immune concepts that are going to answer 80% of the exam questions and, more importantly, keep kids safe on the hospital floor.
Exactly. We aren't trying to memorize the entire textbook line by line. That's just not practical. We're looking for the patterns. And in pediatrics, spotting the pattern early before the labs come back, before the crash happens, that's the difference between a good outcome and a tragedy.
And we've got a heavy hitters lineup today. We're talking SCID, the bubble boy disease. We're talking lupus, juvenile arthritis, the terrifying ascending paralysis of Guillain-Barré syndrome, and of course anaphylaxis and latex allergies.
It's a mix of chronic management and immediate life-threatening emergencies. It covers the genetic, the autoimmune, and the environmental. It's a huge topic.
So here is the setup for today. I'm going to be the curious learner. I'm the one on the floor who has read the book but hasn't seen the patient yet. I'm going to ask the obvious questions. You are the expert. You're the pediatric nursing coach. You need to tell me what matters and what is just noise.
I can do that. My goal is to help you synthesize this, so when you see a question or a patient, the answer just clicks. We need to bridge that gap between textbook theory and bedside reality.
Perfect. Let's dive into what we're calling the master 80-20 map. Before we get into the specific diseases, you mentioned there are really only 4 patterns or landscapes we need to understand. Walk me through this terrain.
Right. If you zoom out, pediatric immunology really falls into 4 buckets of risk. If you can identify which bucket your patient is in, you know your safety priority immediately. It just simplifies the chaos.
Okay, lay them on me. What's pattern number 1?
Pattern number 1 is the absent defense. This is the infection risk pattern. The prototype here is SCID, severe combined immune deficiency.
Absent defense. That sounds ominous, like a castle with no walls.
It is exactly that. In this pattern, the child simply cannot fight. They have no shield. The walls are down, the moat is dry, and the gate is wide open. So for the exam and for the bedside, the priority is the environment. If they can't fight the infection, you have to make sure the infection never touches them. It's all about strict isolation.
So if I see a question about absent defense, the answer is almost always about keeping things sterile.
Correct. You are the wall, the nurse, the room, the equipment. That becomes the immune system.
Right.
And the can't miss here, the thing that kills the patient, is recognizing that this is a medical emergency. You can't just wait and see. They need a stem cell transplant or they die. It's binary.
Okay. Pattern 2.
Pattern 2 is the self-attack. This is chronic inflammation. We're talking about systemic lupus erythematosus, SLE, and juvenile idiopathic arthritis, JIA.
So instead of having no shield, the shield is bashing them in the face.
That is a great analogy. It's friendly fire. The immune system is hyperactive, it's confused, and it's attacking the body's own tissues. The exam priority here shifts completely. It's a balancing act. You have to suppress the immune system with drugs to stop the damage, but you have to keep them healthy enough to grow and develop.
And what's the can't miss for this pattern?
organ damage, and function loss. In lupus, it's the kidneys. You have to save the kidneys. In JIA, it's the loss of mobility. You're fighting to preserve function while taming the immune system.
Got it. Pattern 3.
Pattern 3 is the ascending threat. This is strictly neurological and airway. The condition is Guillain-Barré syndrome, or GBS.
Ascending is the key word here.
It's the only key word.
Yeah.
The paralysis starts at the feet and moves up. The exam priority is tracking that direction because, and this is the can't miss, as it moves up, what does it hit eventually?
The lungs.
The diaphragm, respiratory failure. That's the crash point. You watch the toes to save the lungs.
Okay, that's terrifying because it feels like a ticking clock. And pattern 4.
Pattern 4 is the immediate collapse. This is shock. We're talking anaphylaxis and latex allergy.
This is the speed round.
It is. The priority is speed of onset. We're talking 5 to 10 minutes and airway management. The can't miss is the administration technique of epinephrine. If you hesitate, you lose the airway. There's no time to consult a textbook here.
Okay, I love that framework. Absent defense, self-attack, ascending threat, and immediate collapse. Now that we have the map, let's zoom in. We're going to do a deep dive on each of these, cross-referencing the disease process with the developmental impact, because this is PEDS, and kids aren't just small adults.
Exactly. You cannot treat the disease without treating the development. A 4-year-old with arthritis is a completely different clinical picture than a 40-year-old with arthritis. The stakes are totally different.
Let's start with the absent defense, SCID, severe combined immune deficiency. Give me the one-line identifier.
This is the bubble boy disease. It is a potentially fatal absence of both T-cell and B-cell function.
Okay, let's unpack the patho in plain English. I know T cells and B cells are immune things, but what's actually happening? Why do we need both?
Think of the immune system like a highly organized military. The T cells are your soldiers. They're the infantry that goes out and hunts down the intruders. The viruses, the fungi, the bacteria. They engage in hand-to-hand combat.
Okay, T cells are the grunts, the front line.
Right. Now, the B cells are your intelligence officers. They remember the intruders. They take a snapshot of the enemy and produce antibodies so that if that enemy ever shows up again, the response is instant. They provide long-term memory and protection.
And an SCID.
You have neither. No soldiers, no intel. The child has essentially zero immune system. It's not just weak, it's absent.
When do we see this? Does the baby come out sick?
That's the tricky part, and that's the exam trap. Usually, no. SCID typically presents within the first 6 months of life, but rarely in the first month.
Why the delay? If they have a new immune system, shouldn't they get sick the moment they take their first breath?
You would think so, but they have a borrowed shield. Maternal antibodies. Mom passes on some protection, specifically IgG, through the placenta. That borrowed immunity protects the infant for the first 3 to 4 months.
Ah, so they are running on mom's battery power.
Exactly. But as that battery fades around month 4, 5, or 6, the infant is left defenseless. That's when the chronic, severe infections start.
Okay, so let's hit the need-to-know core. What are the top findings we're looking for clinically?
You're looking for a young infant, let's say 5 months old, with a history of chronic infections. And I don't mean a sniffle. I mean ear infections that antibiotics won't touch. Persistent oral thrush, that white coating in the mouth that just won't go away, severe diaper rashes, pneumonia.
There's just one thing after another, a constant battle.
Yes, and specifically, we look for opportunistic infections. These are bugs that wouldn't hurt you or me because our immune systems would squash them instantly. But in an SCID baby, they can be lethal. Think things like pneumocystis pneumonia.
And how do we confirm it? What's the diagnostic path?
It's genetic. There are 5 different types classified by the exact genetic defect X-linked or autosomal recessive, but the diagnosis comes down to looking at the blood and seeing absent T and B cells. The lymphocyte count will be incredibly low. In many places now, it's actually part of the newborn screen, so we can catch it before they even get sick.
You mentioned earlier this is fatal without treatment. What is the intervention?
The immediate bridge is IVIG intravenous immunoglobulin. We are literally infusing them with someone else's antibodies to buy time. We're refilling that battery. But the cure, the only cure, is a hematopoietic stem cell transplant, an HSCT. We have to replace their bone marrow so they can build their own immune system.
Here is a question for the exam side of things. If I see a question describing a rare X-linked disorder with absent B and T cells, I shouldn't hesitate.
Don't hesitate. It's SCID. And remember, X-linked means it's much more common in boys.
Now let's talk development. Because if I'm a nurse caring for a baby who has to be in strict isolation, that sounds like a developmental nightmare.
It is. Think about how an infant learns. They learn through touch, through putting things in their mouth, through seeing facial expressions. If everyone entering the room is in a gown, mask, and gloves, and the baby is kept in a sterile bubble,
They miss out on bonding. They miss out on the human connection, all those little cues.
huge risk for failure to thrive, not just physically but socially. They can become withdrawn. They don't learn those early social interaction skills.
So what's the nursing action? How do we fix that? What can we actually do?
We have to facilitate sterile bonding. We encourage parents to be in the room, but we teach them rigorous scrub techniques. We use sterile toys. We can't just leave them in the crib. We have to provide sensory stimulation safely. We talk to them. We play music. We use high contrast cards. We find ways to interact through the barrier.
It's a balance of keeping them alive versus keeping them, well, human.
Precisely. And for the nice to know category, while there are different genetic types, the clinical management is the consensus. Protect the child with isolation, bridge with IVAG, and cure with a transplant. That's the core pathway.
Got it. Let's move to pattern 2, the self-attack. We'll start with SLE. Systemic lupus erythematosus. What's the identifier here?
The butterfly disease. It's a multi-system autoimmune condition with unpredictable flares.
Multi-system is a word that scares students. It means it's everywhere.
It means the body creates antibodies against its own DNA and tissues. And since your DNA is in every cell, the inflammation can happen anywhere there's connective tissue. Joints, skin, kidneys, brain, heart, you name it.
But the hallmark, the thing that screams lupus on a test.
The malara rash.
Yeah.
A red rash that spreads across the cheeks and bridge of the nose in the shape of a butterfly. It's very distinctive.
Okay. So, need to know. Top findings.
Aside from the rash, you're looking for a course of remission and exacerbation. They have quiet periods and then flares. So a kid might have joint pain, a low-grade fever, and that rash for a few weeks and then goes away.
What triggers a flare? What makes it come back?
Stress is a big one. Any kind of infection. But a huge exam point is sunlight. UV exposure can trigger a lupus flare. These kids need to be very careful in the sun. Sunscreen, hats, long sleeves.
And the treatment isn't one size fits all, right? I imagine it's pretty complex.
No, it's stratified by severity. If it's mild to moderate, mostly joint pain or skin issues, we use NSAIDs and maybe low-dose corticosteroids. We might use antimalarials like hydroxychloroquine, which is surprisingly effective for controlling the skin rashes and joint pain.
But if it's severe, if it's attacking major organs?
If the organs are being attacked, specifically the kidneys or the brain, we go to high-dose corticosteroids and immunosuppressives, things like mycophenolate or cyclophosphamide. We have to bring out the big guns to stop the organ damage.
Let's talk about that exam tip you mentioned earlier regarding the can't miss, the kidneys.
Yes. Lupus nephritis. This is the major cause of morbidity and mortality in pediatric lupus. If a child with lupus starts having high blood pressure or dark, foamy urine, that's hematuria and proteinuria or swelling, edema in the face and hands, that is the priority. The rash is annoying. The kidney failure is deadly.
So if I'm the nurse, I'm watching the urine output and the blood pressure like a hawk. Daily weights, too.
Absolutely.
Yeah.
Strict intake and output, daily weights, you are monitoring for renal failure.
Now, development. Lupus often hits in adolescence, right?
It's much more common in girls, often presenting around puberty. Hormones seem to play a role. And think about being a 15-year-old girl.
Oh, man. Body image is everything. Fitting in is everything.
Exactly. You have this butterfly rash on your face. You might be losing hair, which is called alopecia.
Yeah.
And the treatment, high-dose steroids.
Which cause moon face and weight gain and acne, the trifecta of teenage nightmares.
It is devastating. The non-compliance rate in adolescents with lupus is incredibly high because they hate the side effects of the drugs. They would rather feel sick than look different.
That's a huge nursing insight. If you have a teen whose lupus is flaring and they swear they are fine, ask if they're actually taking their meds.
Right, and you have to approach it without judgment. I know the prednisone makes you feel puffy. It sucks. But we need to save your kidneys. It's a constant negotiation.
And school is another factor.
The fatigue during a flare is real. It's not just, I'm tired. It's bone-deep exhaustion. They might need a modified schedule, late starts, or rest periods. They aren't being lazy. Their body is fighting a civil war.
Okay, let's stay in the self-attack pattern, but move to the joints. Juvenile idiopathic arthritis, or JIA. Is this just grandma's arthritis, but in a kid?
Definitely not. Grandma's arthritis is osteoarthritis wear and tear. The cartilage wears down over 70 years. JIA is autoimmune. The immune system is actively targeting the synovial fluid in the joints, causing massive inflammation. It's an attack, not wear.
So the joint is swollen, hot, red, and painful.
Exactly. And unlike grandma's arthritis, which gets worse the more she uses it, JIA stiffness is often worse in the morning after inactivity. We call it morning gelling.
What's the goal here? What are we trying to achieve?
The priority goal is to promote a normal lifestyle. That's what you're looking for in an exam.
That seems ambitious if your joints hurt all the time.
It is, but it's critical. If a child with JIA stops moving because it hurts, the joints stiffen up, they get contractures where the joint freezes in a bent position, they lose muscle mass. So the management is pain control plus maintenance of mobility.
It's move it or lose it.
Literally. We want them in physical therapy, occupational therapy, playing, going to school.
So the meds. We see a similar list to lupus.
Similar. NKIs like naproxen or ibuprofen are first line for inflammation. Corticosteroids for flares may be injected right into a joint to calm it down. But here we see a heavy reliance on DRs, disease-modifying antitraumatic drugs, things like methotrexate and the biologics like etanercept.
We'll get to the specifics of those in the med module, but for the JIA section, what's the need-to-know exam tip regarding outcomes?
The goal isn't just stop the pain. If an exam question asks what the outcome goal is, it's participation in school and activities. It's keeping them moving. The answer isn't pain score of 0. It's child attended school all day.
Developmentally, how does this play out? What are the risks?
Physically, we worry about delayed motor skills.
Yep.
If a toddler has JIA in their knees, they might not want to walk. They might revert to crawling. That's a red flag. It can also affect bone growth. One leg might grow longer than the other if the knee joint has chronic inflammation.
And socially?
Recess.
Yeah.
Sports. If you can't keep up with your peers, you get isolated. You become this sick kid who sits on the bench. It could really impact their self-esteem.
So nursing action might be coordinating meds around school?
Exactly. Give the NSAIDs or a warm bath in the morning. The heat helps loosen the stiff joints so they aren't hobbling when they get to school. Make sure pain control is active during recess time. It's about planning ahead to maximize function.
And there is a weird nice-to-know complication with JA involving the eyes.
Yes, uveitis or iridocyclitis. Inflammation of the eye can be totally asymptomatic but can cause adhesions and visual loss, even blindness if untreated. These kids need regular slit lamp eye exams with an ophthalmologist, even if their joints feel fine. It's a silent threat.
That is a great nugget. Moving on. Pattern 3, the ascending threat, Guillain-Barré syndrome, GBS.
This is one of the most distinctive patterns in medicine. Once you see it, you never forget it.
One-liner?
The ascending paralysis that follows a virus.
Okay, break down the timeline. You said it follows a virus.
Yes, the history taking is key here. The child usually had a stomach bug like Campylobacter or a respiratory infection about 2 or 3 weeks ago. They got better, but the immune system got revved up to fight the virus and then it got confused. It's called molecular mimicry.
Confused how?
It starts attacking the myelin sheath of the peripheral nerves. The proteins on the nerve sheath look similar to the proteins from the virus.
The myelin sheath is like the insulation on a wire, right?
Correct. It helps the electrical signal travel fast. Without it, the signal leaks out or moves too slowly, the nerve stops working. It's called demyelination.
And the direction is key.
Ascending. Always ascending. It starts in the toes and feet. The child might complain of tingling or their legs feeling heavy. Then they start tripping. Then they can't climb stairs. Then they can't walk.
No, it just keeps moving up.
Legs, then hips, then torso, then arms, then face, which affects swallowing and facial expressions.
And the need to know crash point.
Respiratory failure. If that paralysis reaches the diaphragm,
Yeah.
which is a muscle controlled by peripheral nerves, they cannot breathe. They literally suffocate because their muscles can't pull air in.
So if I have a patient admitted with weakness in legs suspected of GBS, what is my priority assessment? Am I checking their reflexes?
Reflexes will be absent, yes. That's a diagnostic clue. Areflexia. But your priority is respiratory effort and swallowing. You are watching for the ascent. You're checking their respiratory rate, their oxygen saturation, and asking them to cough. Can they manage their own saliva? You need to anticipate the crash before it happens. You keep the intubation kit nearby.
What is the treatment? Do we give antibiotics?
No, it's not an active infection anymore. It's an immune response. The management is symptomatic, supporting the body while the nerves heal. We treat the immune response with high-dose IVIG or plasmapheresis.
Plasmapheresis is like dialysis for the blood.
Sort of. It filters the blood to remove the bad antibodies that are attacking the nerves, but mostly it's supportive care. Ventilation, nutrition, skin care, preventing blood clots.
And the timeline for recovery.
It is slow. Weeks to months, sometimes years. And interestingly, it heals in reverse. It descends. Function returns from the head down to the toes. The arms get better before the legs.
Let's talk development. Imagine a 4-year-old who was running around yesterday and is bedbound today.
It is terrifying for them.
Yeah.
High anxiety, fear. Their brain is working perfectly. They are fully conscious, but they are trapped in a body that won't move.
Regression must be huge.
It is. A potty-trained child might start wetting the bed because they lose bladder control. They might want a pacifier again. They lose their independence completely.
And looking long-term?
Missed school, a ton of rehab to relearn motor milestones. They might have to learn how to walk again, how to write again. The nurse needs to be the cheerleader here, validating their fear but tracking their progress. Look, you wiggled your big toe today. That's huge.
Okay, pattern 4, the immediate collapse.
Yeah.
Anaphylaxis and latex allergy.
This is the hyper response. This is the body overreacting to a specific trigger.
Patho in plain language.
The body sees an allergen latex, bee sting, peanut, and the immune system, specifically IgE antibodies, triggers mast cells to dump a massive amount of histamine and other chemicals. Histamine causes 2 main things: vasodilation and bronchoconstriction.
Vasodilation means
Blood vessels widen and become leaky, fluid leaks out into the tissues, blood pressure plummets. That is shock.
and bronchoconstriction means
The smooth muscles around the airways tighten, the airway swells, no air gets in.
a deadly combination.
Within 5 to 10 minutes, it's incredibly fast.
So, need to know. Symptoms.
Hives, we call that urticaria. Wheezing, cough, shortness of breath, nasal congestion. But look for the feeling. The sense of impending doom. Kids often say, something feels wrong, or my throat feels itchy, or my tongue feels thick. You have to listen to that.
And the latex specifics. The source material highlights this. Why latex?
Latex is a specific allergy, often seen in kids who have had multiple surgeries, like children with spina bifida, because they've been exposed to so much latex tubing and gloves early in life, their body becomes sensitized to it.
And the priority intervention. There's only one, right?
Epinephrine.
Yeah.
The EpiPen. It's the only thing that will reverse both the vasodilation and the bronchoconstriction.
Do we wait to see if it gets worse? Maybe give some Benadryl first.
Never. If there is airway involvement or circulatory collapse, you give the epi. Better to give it and not need it than need it and be too late. Antihistamines like Benadryl are not enough for anaphylaxis. They are way too slow and they don't support blood pressure.
Developmentally, how does a severe allergy affect a kid?
It creates fear. A constant low-level anxiety. Fear of food, fear of birthday parties, fear of the environment. Can I eat this cupcake? Will it kill me?
So education is the intervention.
Teaching the child age appropriately how to avoid triggers, teaching the parents how to read labels, and teaching everyone, the child, parents, school nurse, teachers, how to use the auto-injector. Blue to the sky, orange to the thigh.
Okay, we've covered the diseases. Now I want to move to the medication module. We have a specific list of drugs from Chapter 25. I want to do a rapid-fire review, but specifically focused on the pediatric pearls, the stuff that is different for kids.
Let's do it.
First up, 5V immunoglobulin, IVIG. We mentioned this for SCID and GBS.
Right, it's either replacing the defense or modulating the immune system.
What's the PD-specific pearl? What do I need to watch for?
The administration. You have to watch these kids like a hawk during the infusion. Vitals every 15 minutes at the start. Reactions, fever, chills, headache, nausea can happen fast. In a baby with SCID, that reaction can be destabilizing. Also, hydration is key. IVG is thick. He can be hard on the kidneys. They need to be well hydrated before you even start.
Next, corticosteroids. Prednisone, we use this for lupus and JIA.
The mechanism of action is anti-inflammatory and immunosuppressive. It puts out the fire.
PEDI pearl.
Growth. Long-term steroid use stunts height, it affects bone density, leading to osteoporosis later, and it causes that Cushingoid appearance, the moon face, the buffalo hump, of the central obesity.
So if a parent asks, will this stunt his growth?
The honest answer is it might, but we weigh that against the organ damage from the lupus. It's a trade-off. Also, safety. Steroids, VASC infection. A kid on steroids might have a raging infection but no fever. The usual alarm bells don't ring. You have to be hypervigilant for subtle signs of sickness, like just being more tired or irritable.
Third, NSAIDs, ibuprofen, naproxen, for mild lupus and JIA.
Goal is pain control to allow mobility. They reduce inflammation.
PEDI pearl.
GI upset. Kids often won't say, I have heartburn. They'll just refuse to eat or say their tummy hurts. Always give NSAIDs with food or milk, and watch for easy bruising as they can affect platelets slightly. And never, ever give aspirin to a child with a viral illness because of the risk of Ray's syndrome.
Fourth, DARNs. Methotrexate, etanercept. These are the heavy hitters for JIA.
These suppress the immune system significantly. Methotrexate is actually a chemo drug used in lower doses for arthritis. Etanercept is a biologic that blocks a specific inflammatory protein called TNF-alpha.
The exam warning. What's the biggest danger?
If a child on methotrexate develops a fever, it is a medical emergency. They are at risk for sepsis. They don't have the reserves to fight it. You don't just give Tylenol and wait. You go to the ER for a full workup.
Oh.
Also, for adolescent girls, methotrexate is teratogenic, causes severe birth defects. You have to talk about pregnancy prevention, which is an awkward but necessary conversation.
Finally, epinephrine.
For anaphylaxis, it's a non-selective adrenergic agonist,
Teddy Pearl.
teaching the child. Even a young child can be taught that the pen is their friend. And parents need to know it goes in the outer thigh, the vastus lateralis muscle, and you have to hold it there.
Hold it for how long?
Count to 3 or 10 depending on the brand, but hold it firmly in place. Don't just jab and pull. You need to ensure the full dose is delivered into the muscle. And always call 911 after using it because a second reaction can happen.
Okay, we're in the home stretch. I want to do some cross-linking. We've hinted at these, but let's make the connections explicit.
Great. This is where the patterns really come together.
Connection 1, the latex food connection. Why do we care about food if the kid is allergic to latex gloves?
Because of cross-reactivity. The proteins in latex look very similar to the proteins in certain foods. It's a case of mistaken identity by the immune system.
Which foods are we talking about?
We call it the tropical fruit salad. Bananas, avocados, kiwis, chestnuts, papaya.
So if I have a latex allergic kid, I'm taking the banana off their lunch tray.
Absolutely. You treat those foods as potential allergens. And conversely, if a kid has a severe allergy to bananas, you should be suspicious of latex and use non-latex gloves.
Connection 2, the steroid trade-off. We talked about growth, but let's talk about the psychological aspect again.
In conditions like SLE and JIA, the treatment can feel worse than the disease to the child. The mood swings from steroids, roid rage, plus the weight gain, plus the acne.
It creates a compliance battle.
It does. And as a nurse, you have to validate that. You cannot just dismiss their vanity. To a teenager, appearance is reality. I know you hate this medicine, but we need to save your kidneys. It's a hard conversation, but empathy is the key to compliance. You have to be on their team.
Connection 3, the infection loop.
This is the biggest safety takeaway. SCID patients have no immune system naturally. SLE and JIA patients have suppressed immune systems artificially because of the meds we give them.
So the result is the same. They're both vulnerable.
Exactly. Both groups require a neutropenic precautions mindset. Fever is the enemy. Crowds are the enemy. And here's the big one, live vaccines.
Tell me about live vaccines. Which ones are those?
Live vaccines like MMR for measles, mumps, rubella, varicella for chickenpox, rotavirus, and the nasal flu spray are generally contraindicated because their body can't handle even the weakened virus. You could actually give them the disease you are trying to prevent.
That is a massive exam point. No live vaccines for the immunosuppressed kid.
Massive. Can't miss it. If you see an order for MMR on a CID baby or a kid on high-dose steroids or methotrexate, you question that order. You protect your patient.
We have covered a ton of ground. We've mapped the landscape, dived into the diseases, reviewed the meds, and connected the dots.
We have. It's a lot of information, but remember the patterns. It helps organize everything.
Before we wrap up, I want to leave the listeners with a final thought, something to chew on.
I'd like to challenge everyone to think about the concept of invisible illness.
Go.
In pediatrics, we're used to looking for the obvious. The crying baby, the bleeding wound, the high fever. But the conditions we discussed today, JIA or early GBS, or even lupus between flares, often present quietly.
They don't look sick at first glance.
Right. A child with JIA who doesn't want to run at recess might just look lazy to a teacher. A baby with GBS who's getting floppy might just seem tired or fussy to a parent. A teen with lupus fatigue might just look like a moody teenager sleeping all day.
And the nurse's job?
Your job is to look past the surface, to see the pattern, to notice that the laziness is actually stiffness that's worse in the morning, to notice that the fussiness is actually ascending weakness, to notice that the moodiness is pathological fatigue. You have to be the detective before the crash happens.
That gives me chills. It's not just about passing the test. It's about being the one who notices.
Exactly. That is the essence of pediatric nursing. You are the voice for the child who can't explain why they feel wrong.
Thank you. This has been an incredible survival guide.
My pleasure.
To our listeners, take these patterns. Absent defense, self-attack, ascending threat, immediate collapse. Keep them in your pocket. ace that exam, but more importantly, keep those kids safe on the floor. You've got this.
See you next time.
This has been The Deep Dive. Signing off.